All right, Betty, are we good to begin? All right, I think we'll go ahead and get started. Good evening, everybody, and welcome to the 2025-2026 General Surgery Review hosted by SAGES. We're very excited to have you all joining us again for our 11th year of this program. We've been very fortunate to touch tens of thousands of folks worldwide and to welcome you all again this year for what tends to be a very well received and popular session. I'd like to welcome and introduce Dr. Ivy Haskins, who is co-chair of this phenomenal program with me. Welcome, Dr. Haskins, and thank you all for your work involved as well. We have a phenomenal array of panelists here that we will introduce as each of their sections come about. I'm going to go ahead and bring up my slides, and then we will go ahead and dive in as we've got a packed session for you all here. So again, welcome to the SAGES General Surgery Review. Again, I'm Michael Awad, and Dr. Haskins and I will be ushering us through our agenda this evening. We'll be starting off with 4 sections. We go over this in 2 parts. First part is this session, and then we'll have the second part in January. Today, we'll go over esophagus, stomach, and obesity with Dr. Haney. Dr. MacGregor will lead us in a discussion about general abdomen, hernia, and spleen topics. Dr. Sylla on colorectal and anal disease. And then finally, Dr. Deal, a collection of topics on small intestine, biliary disease, and flexible endoscopy. So a 2-hour session overall. Again, we are extremely grateful to the Society of American Gastrointestinal and Endoscopic Surgeons, SAGES. This has been a phenomenal group that I have had the privilege of calling home as my professional society for over 20 years since I was a trainee myself. Just a phenomenal, vibrant organization with its vision of reimagining surgical care for a healthier world. Its mission is to innovate, educate, and collaborate to improve patient care. And the values you can see there: inclusivity, innovation, service, excellent, establishing a global community, and of course, fun. And hopefully we'll have a little bit of that this evening as well too. If you're not already, I would very much encourage you to sign up for SAGES, especially if you are a candidate, a trainee member. There's really no reason not to join. There's just a marginal fee for candidate members. Your membership can be rolled over into full membership when you finish your program. When you are a member, you get a huge discount to attend the SAGES meeting. And if you haven't been to the annual meeting, I'd strongly encourage you to. It's a phenomenal packed program of education and professional development. There are over 7,000, actually now 8,000 members within SAGES that you'll have access to and collaborate with. You'll get an online subscription to a high impact journal, Surgical Endoscopy, which I think many, if not all of you, have read, and access to tremendous opportunities such as research grants, career development awards, committees where you can make a huge difference. In SAGES, we call a meritocracy, where if you do the work, you get recognized in advance too. Again, we have several membership tiers that we'd encourage you to go to sages.org/membership to learn more and hear more about. And then again, the annual meeting coming up in the spring in March 25 through 28. It will be in Tampa, Florida. Hopefully a nice warm time for us to visit Florida in the spring. Again, this has been just a tremendous meeting and a professional home. And would encourage all of you and hope to see all of you there in the spring. Now, a little bit more about this evening. So again, this is kind of based on the outline of the American Board of Surgery in-service training exam, the ABSITE. This evening, we'll be covering the first half of the topics you see on the top of the spreadsheet here. By popular demand several years ago, we also started including the additional topics that you see here on the webinar as well. So between the 2 sessions, you will cover the entire span of topics that are covered on the ABSITE. The format for this evening will be kind of a rapid fire series of multiple choice questions. that are moderated by each of the panelists. They will read the question, and then you'll have in your Zoom interface a poll that comes up. We would encourage you to respond to the poll. We will show the poll responses and talk about why the certain answers were correct and why certain answers were incorrect at the end. So it'll be a live interactive and a chance for you to kind of get warmed up for the app site. We'd also like to acknowledge TrueLearn. TrueLearn, many of you maybe have used as a resource. It's kind of a data bank of high quality exam questions that have great figures and rationales to explain them. We have a partnership with TrueLearn, and those are the questions that you'll be seeing here today. So that's kind of the ground rules. Again, thank you to all our panelists. We're going to start off with our first panelist, which is Dr. Olivia Haney. Dr. Haney has been, we've been excited to welcome as a panelist for the last several years. She is a minimally invasive and bariatric surgeon in the Northwell system at Staten Island University Hospital, and she does a wide range of MIS and GI procedures with a focus on laparoscopic and robotic bariatric surgery. Dr. Haney, so happy to have you here. Thank you so much for making time to be with us and share your expertise.
Awesome. Well, thank you for having me. And I'm so excited to be here again for another year. And I think it's so fun to go over all the ABSITE questions. It's that little fun we bring from stages, but really the best way to learn is by doing questions. I think having someone there with a little more expertise, like Dr. Sylla, amazing, Dr. Deal, right? All of these people are going to be like the experts in the matter. So, this is a good opportunity, and we're excited to have so many of you guys here with us tonight. Sorry, my voice has gone a little bit. I had a cough last week, so doing my best. All right, so the first question, you guys are already beating me to it, but which of the following are diagnostic findings of Barrett's esophagus? I'm going to give you a second, and we've given you a little bit of time while I was just rambling on, but
and Dr. Haney, if you could also read the options as well.
Yes, thank you. Sorry. So the first one is ciliated pseudostratified columnar cells. B is goblet cells. C, stratified squamous epithelium. D, aggregated lymphoid nodules. And E, Samoma body. I know you just wanted me to say Samoma body. That's a good word. It's a fun word. So
you did it great. You did
perfect.
Thank
you. Thank
yes,
you.
Yes, that's a tricky one.
That's a tricky one. A lot of consonants in that word. So, all right. So
hopefully
okay.
everybody's seeing their Zoom poll come up. We have a number of respondents, but if you haven't already, please click on your Zoom poll to respond.
So this is exactly what I thought was going to happen with this question. Now, almost half of you guys got it right. 44% of you guys got it right. It's goblet cells. But see how A was tricky? A said ciliated pseudostratified columnar cells. So you saw that word columnar and you locked onto it, because we all know that with Barrett's esophagus, it changes, right, from the squamous epithelium to intestinal columnar epithelium. But that didn't, they were trying to trick you up with the ciliated pseudostratified columnar cells. It's intestinal metaplasia with the goblet cells. So it's a little bit tricky. I'm not going to lie. That's kind of an unfair question, but it's just getting almost like a next level of what you actually know, right? So it's like beyond what you know. So good to the 44% of you that got that right. But the ciliated pseudostratified, as it says there, is actually in the respiratory tract. So, all right, but good way to kick it off. I love it.
And Dr. Haney, while we're on the first question here, I just want to orient folks who haven't used TrueLearn before. A couple nice things that you'll see when you respond to a question. You'll see the actual distribution of other TrueLearn participants and how they responded. And you can see that similar to our poll, it was not universal. So you can see why this question is tricky. On the right side, it will give you the bottom line. And it will give you a much more detailed explanation with kind of rich figures. It will give you a rationale for why the other answers were not correct, and links to references that you can look up if you want to read more. So a very nice resource. Yeah.
All right. So question number 2, we have a 52-year-old man presents to the emergency department with acute onset of chest pain after a bout of forceful vomiting After choking on a fishbone, on examination, he is short of breath, tachypnic, and diaphoretic. Chest x-ray shows a small pleural effusion on the left. A non-contrast CT shows pneumomediastinum. What is the most common non-iatrogenic cause of esophageal perforation? A, Borheim syndrome, B, endoscopic instrumentation, C, foreign body ingestion, D, malignancy, or E, trauma. So this is one of those fun questions where you could just like skip the whole thing and read the last sentence, but you never know till you get there. Sometimes it's
And
good, a test-taking tip, read the last sentence, then go back and read the question. That's not a bad test-taking tip. Kind of can save you some time when it's stuff like that. So,
that's a
all right.
great tip, Dr. Haney, especially with the long stem. I think it
Yeah,
can be helpful to get to the bottom line as
yeah,
you're determining what information is important and less
right.
important.
Figure out what words you even need to look at. So,
Yeah.
okay, good. So, good job. Again, wow, 44% of you are right on track again. Borheim syndrome. So it's asking you what's the most common non-iatrogenic cause of esophageal perforation. Now, maybe this little fishbone caused it, but according to this, right, only 12% of spontaneous perforations are accounted for that. And it's the vomiting, right? It's the forceful vomiting. So that's more likely to cause this esophageal perforation that you're seeing here. That's causing this pneumomediastinum, all of these symptoms, than this little fishbone. And based on these statistics alone, they're asking an underline most common non-iatrogenic cause. So that's esophageal perforation. And then just make sure you read the question because other things, endoscopic instrumentation, right? That's an iatrogenic cause of esophageal perforation and the most common cause of that. So, all right, perfect. I think that was pretty good. I think you guys did
And
pretty well
Dr.
on that one.
Haney, I was remiss for the participants who are on. You also should have a Q&A feature.
Oh yeah.
The chat itself is locked, but the Q&A is available. So if you have, we will do our best to try to get to
Hmm.
questions, and we can only do so through the Q&A. We can't do so verbally, but please, if you have any, put them through the Q&A. Thank you.
All right. Next question. We have an otherwise healthy 71-year-old man with cervical stenosis who presents as an outpatient complaining of dysphagia, chronic cough, and halitosis. A contrast esophagogram demonstrates cervical esophageal pouch with retained contrast. The treatment to correct symptoms and reduce the risk of recurrence in this patient most likely include A, initial endoscopy to confirm the diagnosis, B, diverticulopexy alone for an adequately sized diverticulum, C, endoscopic diverticulectomy, D, an open cricopharyngeal myotomy through an incision in the left neck, and E, an esophageal myotomy opposite to the defect. All right,
Good.
so this is one of those best, most likely questions, right?
Yes.
Yes, interesting.
Yeah, lots of thoughts on this one. Yeah, people.
Yeah, I think it's a good one. All right, good. So, all right, a little bit less of you, but this is a pretty tricky one. This is one where I feel like you need to know, like, and you can see here, less of the true learn people actually got this one right too. So this is why we chose these questions. We didn't choose like the hit them out of the park questions because you don't need to review those, right? But we wanted to go over some of the more complicated questions. So there can be the transoral approaches or the open approaches. One thing I taught last year, which I think, I don't know, Dr. Awad liked my little left, right, left situation. So I'll say it again. If you want to do high in the neck, it's left, and then it's right side for mid, and then left on the other side. And that's like an army march, like left, right, left. So anyway, that's how I always remembered that. But that's another topic exactly. But the answer here is D. And the reason they say is because they talk about this cervical stenosis this patient has because of the extension of her neck. So that's the thing I think is kind of outside of things that we normally think about. And then saying that that's like the most likely to reduce the risk of recurrence. So that's if you look at the question overall, you want to see the one that's most likely to reduce the risk of recurrence and correct the symptoms. Now, in practice, maybe you do something else, But we're looking for like the standard of care, most likely question for this app site question. So a little bit trickier. Um, so that's just something to think about, something to study up on for sure.
Yeah, I think a key part of this question is also the myotomy.
Yeah,
Just treatment of the diverticulum without the myotomy
true,
is,
true, true.
a big part of why the symptoms can recur. So you can look and eliminate, all of the
Yeah,
responses that don't include a myotomy, and that
yeah.
kind of leaves you with B and E. And then
Hmm.
D is the one that, also is kind of dealing with the esophageal myotomy opposite to the defect won't be sufficient because
Yeah,
it's the right by the diverticulums. That's the Killian's triangle, and it's the issue.
exactly. Thank you,
Good.
Dr. Owen. Yep. All right. All right. Next question. We have a 45-year-old man with a long-standing history of peptic ulcer disease refractory to medical treatment presents to your clinic. After a complete workup, he is scheduled for a truncal vagotomy with antrectomy. Which of the statements is true in regard to the anatomy of the vagus nerve? A, the anterior vagus nerve gives rise to the hepatic branch. B, the anterior vagus gives rise to the criminal nerve of Grassi. C, truncal vagotomy requires only division of the anterior vagus. D, the left vagus becomes the posterior branch. And E, the anterior vagus gives rise to the ciliary plexus. That's a lot of words. I got it. This is one of those you know it or you don't questions. So um, take a little bit of time, but I always say, like, you don't know it, this one, you just go with your gut and move on. You don't want to waste time on questions that you can't really think through if you don't know it. So that's sort of a sad test taking tip, but it's still a test taking tip.
I always get a kick out of the terminology criminal nerve of
Right?
Grassi.
I
It's like,
do like that.
what
It's
did it
funny.
do to deserve that?
Oh, I have, while we're here, I can tell you a funny story. A patient called yesterday to say that she was mad because I wrote incarcerated hernia on her note because
Oh
she
boy.
said, I've never been to jail. Anyway, true story that happened yesterday.
Oh
So my
boy.
patients also think they're criminals. So
That's fine. Funny.
all right. Good job, you guys. Okay. All right. So maybe a couple of you could brush up on your anatomy a little bit. But as you see here, we have this little picture. We could scroll down. Maybe it has a really good picture to show that the right vagus is going to give off it's going to become the posterior vagus. So that gives rise to, as it says, the criminal nerve of Grassi. And then the left vagus becomes the anterior vagus, which gives rise to the hepatic branch. So, this is just sort of like you know it and you don't. There's also that thing that people say, the LARP. I don't know why I always remember that. I don't think there's some sort of mnemonic for that, but I don't remember. But left anterior, right posterior is just something to remember how it twists around. And then you just have to know your anatomy there. But if you know left anterior, right posterior, it might be helpful to kind of guess left and right sided branches. So, all right. We won't belabor that. A 40-year-old man is brought to the emergency department after an episode of hematemesis. He has a history of renal disease. Esophageal gastroduodenoscopy demonstrates multiple esophageal varices with stigmata of recent bleed. There is old blood within the stomach, several gastric varices, but no ulceration. The cause is likely A, post-hepatic due to inferior mesenteric vein thrombosis, B, pre-hepatic due to cirrhosis, C, intrahepatic due to polycystic liver disease, D, intrahepatic due to right heart failure, and E, post-hepatic due to cirrhosis. All right, so, all right, we got some mixed answers on this. We'll give you a couple more seconds. Great. Okay. Oh, there we go. All right, so okay. So I see what you guys were thinking, and honestly, good test taking strategy. B and C are pretty similar. So you're thinking like those might be the right answer. So that's what you guys picked. But actually, this was a little bit tricky. The answer was actually C, um, intrahepatic. So if you look at through the explanation, You think about esophageal varices as a result of portal hypertension, prehepatic causes, we know these things, portal vein, splenic vein thrombosis, and then intrahepatic is things like polycystic liver disease, and then post-hepatic we have here. And the reason, listen, I looked at this, but I'm not a good liver doctor. Maybe let me try to figure out why this is like the best way to explain this to you. Um, mm, it's just the right answer. I don't know. Dr. Awad, help me. It's just,
Yeah. Yeah,
yeah,
no, I think
it's tricky.
the it is a little tricky, and there are multiple, as the question talks about different causes for varices. But I think the clue here was the history of renal disease, and this is a little
Mm-hmm.
bit subtle. So,
That is subtle.
it is, and so here they talk about intrahepatic causes, including infiltrative liver disease, cirrhosis, and polycystic liver disease. And so this is kind of the clue as to what
Oh, because it might have also polycystic kidney disease. This is too
exactly,
much.
exactly.
Oh,
Yes, yes.
this was heavy.
This was
Yeah,
tough. This was
this
tough.
was tough actually. Because when I looked at the explanation, I was like, I mean, sure.
Yes,
Yeah,
yes,
but this is why we're all learning. This is
yes.
why we're in academia, so we can learn together. All right. Good job. Thank you. All right. A 56-year-old woman presents with 6-month history of vague epigastric pain, early satiety, and weight loss. EGD shows a 3-centimeter mass in the gastric cardia. A biopsy reveals adenocarcinoma. An endoscopic ultrasound shows T3N1 disease. Further, metastatic workup is negative. She has good functional status. Performance status number one, ECOG performance status one. What is the most appropriate treatment of this patient? A, palliative chemotherapy. B, total gastrectomy. C, total gastrectomy followed by adjuvant chemotherapy. D, partial gastrectomy followed by adjuvant chemotherapy. And E, neoadjuvant therapy followed by surgical resection. So, oh, this is more in my wheelhouse. The stomach. So, all right, this is good. These are kind of the things you have to look at these the stages, right? The T and M stages. So look about that and see what you think. What do the NCCN guidelines kind of say about that? What does it usually mean to have positive lymph nodes, right? So perfect. Good job, everyone. You crushed this even better than the True Learn people, the general population here. So you see positive lymph nodes and you think probably neoadjuvant chemotherapy. So even if you had to make your best educated guess here, you maybe could have gotten it right. But this is sort of, you would just have to know the reason why we do things, but also knowing the T, N, and M status and what that means is important to answer this question. So I don't think, you know, we need to belabor this too much because you guys did really well. But you would need to have chemotherapy followed by surgical resection. It is still resectable with the
A
one.
couple kind of things in the stem, the good functional status is also, very important. And if you saw that the patient was
Yeah,
a poor surgical candidate, obviously that would clue you
yeah,
into option A, but not the case here. So,
yep, beautiful. All right. So we have a 55-year-old man, otherwise healthy, undergoes an EGD for reflux symptoms and is found to have incidentally have a 3-centimeter smooth submucosal dumbbell-shaped mass in the stomach. Metastatic workup is negative. The treatment of choice is A, observation, B, resection of the mass with 1 centimeter margin, C, resection of the mass with wide greater than 2 centimeter margins, D, imatinib or Gleevec, E, combined chemotherapy and radiation. So another gastric mass, but a very different kind. Um, you guys are doing pretty good so far. I can see um, something actually we see relatively more often, I would say. Well, I do anyway in my practice. Maybe that's biased.
and it will say one of the answers gives you a clue as to what they're referring to here. So,
Ooh, yes, actually, that's a good
yes,
point.
yes.
Yes, yes. All right, so that's right. This is the gist, and as Dr. Awad was saying, I believe that clues you in, right? You're like, oh, interesting. Oh, if you weren't thinking that, you were like, maybe it's a gist. Maybe I should think about that. And we know with that, it's just you want an R0 resection. So you want that to be the margins to be negative. So you don't need a wide resection for a gist. So 1 centimeter margins is really the best answer here. Um, and you don't need chemotherapy or radiation without resection, or even because it's so small, it's less than 5 centimeters. You do want to treat it, and you might need imatinib based on the pathologic findings, like greater than 5 centimeters or greater than 5 mitoses per high powered field, but we wouldn't know that yet. But that's not the best upfront situation. So nice. Good job, everyone. All right. So a 68-year-old man post-op day 7 from a tracheostomy has massive hemorrhage from his tracheal stoma. The patient proceeds to the OR and identifies a tracheoinnominate fistula repaired with resection of the affected portion of the vessel and oversewing of both ends. What is the most appropriate method for repairing the original tracheal stoma after proximal relocation? So this is kind of a dreaded complication of a tracheostomy. And this is sort of the time when you're going to see it, right? It's not usually right after. You're bleeding like day 1. That's probably not it, but you get called to the floor 7 days out. Ooh, you got to be careful. You got to worry about a TI fistula. So, all right. Nice. Good job. You guys are crushing this question. So that's right. You want to use that strap muscle to cover the tracheostomy stoma because you want to encourage it to heal, prevent fistulization, just like with anything that you do. Esophageal perforation, sometimes this, especially, this is using a muscle flap can really help to seal the stoma, and not just like an omental flap. That seems like that would be difficult to bring up anyway. Soft tissue coverage. Primary closure is definitely going to open up, and then secondary wound closure, right, is you're not just going to leave that open because you have that proximal stoma. So nice. And then this is a really nice, they do sometimes on TrueLearn give those really nice graphs. So just go back and kind of review those algorithms. I think it's nice to look at that, and those can give you a good mental picture of what to do in these situations. All right, cool. Thanks, Ben. All right, perfect. Some bariatric stuff. So we have a 52-year-old woman with morbid obesity, 3 months out from laparoscopic adjustable gastric band, presents to the ED with nausea, vomiting, and malaise. On arrival, vitals are temperature 37.2, pulse 113, blood pressure 89/59, respiratory rate 22, saturation 94. They got an upper GI, and it's shown below. So what is the most appropriate treatment for this patient? A, emergency surgical intervention. B, upper endoscopy. C, removal of 2 mLs of fluid from the band. D, inject 2 mLs of fluid into the band. And E, band readjustment. So this is also one of those like figure out what's wrong and then figure out what to do about it kinds of questions. But also looking at the patient's overall status. So that can kind of give you a hint of what is the most, appropriate treatment for this patient at this time. Beautiful. So you guys, you nailed it. Good job. That's that phi angle of a slipped gastric band. So normally the angle should be much more acute. And when it slips like that, we know the fundus is kind of slipping up above the gastric band, and that can cause strangulation of the gastric tissue and necrosis. Yes, sure. If they're not unstable, you can remove a little fluid from the band to just kind of like release some of the pressure. But this patient is unstable, vomiting, tachycardic, hypotensive. So obviously, even if you didn't even know this was a slipped gastric band, you should go to the operating room. But the way that the angle has adjusted down closer to perpendicular to the spine, that is pathognomonic for a slipped band, especially in light of her symptoms, because it's probably causing some gastric wall ischemia. So these just need to be taken out. You don't want to just go in and just redo it. You're just going to take this band out, and you can always live to fight another day and figure out what you're going to do next from a weight loss standpoint. Good job. You guys crushed that one. All right. 52-year-old man with a BMI of 41, diabetes, presents to the ED. He complains of continued epigastric pain after meals that are associated with nausea, early satiety, and vomiting. 6 months ago, he was treated for GERD with a PPI, and He has been compliant. CT scan was negative for any pathology. He has undergone the EGD, esophagram, pH monitoring, and manometry, which diagnosed GERD. What symptom is most appropriate? What surgery is most appropriate given this patient's comorbidities and presenting symptoms? A laparoscopic Nissen fundoplication. B, laparoscopic sleeve gastrectomy. C, highly selective vagotomy and pyloroplasty. D, laparoscopic root-wide gastric bypass. And E, laparoscopic adjustable gastric band. Nice. And obviously, I don't think they're asking you to do this in the emergency department. I think they're asking you what you would do in the office later. That would be kind of a fast bariatric consult otherwise. But good job, you guys. You're doing really well on this one. I think you understand the principles here, right? So he has reflux and class 3 obesity. And so for patients with class 2 or 3 obesity that meet the criteria for bariatric surgery and reflux disease should consider, at least highly consider, a root-wide gastric bypass over a Nissen fundoplication. Your chance of recurrence is going to be much higher. And this is going to allow for weight loss and also resolution of GERD. So this is a great treatment for both of the things. And if you're just looking at the question, what surgery is most appropriate for the comorbidities and presenting symptoms, they're also throwing diabetes in there. They're really trying to get you to do a gastric bypass. So for all of those reasons, you guys know 72% of you said gastric bypass. So sleeve can make it worse. Band is definitely going to make it worse. And the Nissen won't help with weight loss and could recur pretty quickly. So nice job. All right. I wish patients would come to me with all that workup already done. That sounds awesome. All right. So a 39-year-old woman with a BMI of 40 presents for bariatric surgery evaluation. She is given a food diary and a strict diet to follow. On her follow-up in 4 weeks, her food diary shows she's been following the diet and eating mostly lean proteins, fruits, and vegetables. She is approved for bariatric surgery and does not continue to make entries in her food diary. On the day of surgery, she has gained 2 kilograms and admits to having eaten fast food the past few days. Which of the following concepts correctly describes the situation? A, Hawthorne effect. B, observer bias. C, recall bias. D, effect modification. E, follow-up bias. This is one of those stat questions disguised as a surgery question. They're going to be there. It's just, it's a good one.
Yes.
Just the way they do it. And it's actually kind of a nice question. So. All right. Interesting. I like it. I think most of you guys are right on the right track. So we had most people answering A, Hawthorne effect, and then some other people thought effect modification, which honestly, like the way the words are, that's kind of an interesting thing to think about. But we know that the Hawthorne effect is when you start observing someone and they change their behavior. So they're knowing that their diary is going to be read and that they're going to be looked. And so then once we start taking this observation period away, they gain the weight back. And then they're saying from the effect modification, that's something different. For example, they're saying here, for an example, in case of asbestos exposure, smokers and non-smokers who are exposed to asbestos have a risk of lung cancer. However, the presence of smoking history increases the risk. So it's like an effect modification. If they smoke or not, smoking and non-smoking are different than asbestos. It's like the effect of smoking increases the risk of cancer in asbestos patients. So it's like very different. The words seem like something you would want to say for this, but it's very obviously the Hawthorne effect. So don't let them trip you up with different lesser things that it could be. Go with what you know. So that's right. That's a good one. All right. What percentage of patients have resolutions of pseudotumor cerebri following bariatric surgery? We've got A, 75%, B, 80%, C, 60%, D, 30%, and E, greater than 90%. This is also kind of one of those like, you know it or you don't questions. They have pretty good data on this. So they love to ask these types of questions about diabetes, sleep apnea, hypertension, reflux, and then also this. This I feel like comes up less often, but we know good data on this, so it's a good thing to ask questions on things that they have numbers to ask. So yes, good job. Interesting distribution here. Something that you guys can take a look at, this little solution here. We have pseudotumor cerebri is associated with the highest resolution rates following bariatric surgery. It is heavily associated with weight gain. So that makes sense, is that weight loss almost completely eradicates it. And then the next biggest thing is usually sleep apnea. And then then following that is diabetes, following that is hypertension. And then, I guess they're saying GERD, which actually can resolve in sleeves with weight loss. So, really, if you think about the order of operations, student tumor, sleep apnea, then diabetes, hypertension. So, like, that's sort of the way that it goes from a comorbidity resolution standpoint.
And I would just say this one also has kind of a test-taking tip in it as well. When you look at the
Yeah.
responses, you see, two responses very close to each other, 75 and
Mm.
80%, and they're
Hmm.
never going to ask you ones where you have to like,
Nitpick.
thread
Yeah.
the needle. Yeah, so
Yeah.
close. So automatically you can take those two out. You know what they're looking for is it very high, very low, or kind of somewhere in the middle? And so that also kind of
Yeah.
clues you in. So just process of elimination. So all right, last question in this
No,
section.
that's a great tip. Also, a good one to use on rounds. An attending used to say you can usually say 25 or 75, and you're probably going to be like, oh, you're pretty close on either one of those. So just saying, it works for me. Um, all right. So we have a 55-year-old woman with a history of prior laparoscopic fundoplication for reflux 1 year ago who presents to your office with nausea, bloating, and early satiety. She denies reflux or regurgitation of food. In addition to upper endoscopy, results of which of the following studies may lead to consideration of a partial gastrectomy with Roux-en-Y reconstruction over a revised fundoplication? So this is sort of like a multiple part question. You've got A, gastrograph and swallow, B, 24-hour pH monitoring, C, nuclear medicine gastric emptying study, D, esophageal manometry, and E, abdominal MRI. So you got to look at the different parts of the question. What's her history? What are her symptoms now? She's getting this upper endoscopy, which is what we're always going to start with. And then, so what do you think the diagnosis is? And how would we kind of confirm that diagnosis to lead you to this surgery? They're giving you a hint here. They're saying leads to a consideration of a partial gastrectomy with Roux-en-Y reconstruction over a revision fundoplication. So which one of those would lead you in that direction? You guys are doing a good job here. Good. All right. Half of you guys did get the right answer. So why would you do, right, a partial gastrectomy with Roux-en-Y versus a revised fundoplication if you had gastroparesis? And that could be caused from a vagus nerve injury from the initial operation. Or some people just have it pre-op and you might not have diagnosed it up front, right? So, but this is saying probably from a vagal nerve injury. If you didn't have gastroparesis, you might be able to just revise it, right? But the symptoms are nausea, bloating, early satiety. You're not just going to go in and revise that fundoplication. But they're pointing you in 7 different directions towards a gastric emptying study in this question stem. And so you want to get that. And at that point, a Roux-en-Y gastric bypass, you don't want to just do the Roux-en-Y and not take the partial gastrectomy out because that remnant stomach is still going to have symptoms of gastroparesis. They're still going to have pain, bloating. They can still get nausea. So that's why they're saying that partial gastrectomy is part of that Roux-en-Y reconstruction. So yeah, all right. And then the other ones won't really give you as much information on it. But good job on that, you guys. We're going to keep moving down the body. Thanks for bearing with me. And it's been fun per usual. So
Dr. Haney, thank you again so much. Really appreciate your time and expertise in this initial section. I'm
and
gonna hand it off
I'm gonna
to.
go study about cirrhosis now. So
All right, good deal. I'm gonna pass off to my co-chair, Dr. Haskins, who will introduce our next speaker.
All right, so next up is Dr. Robert MacGregor. He is currently an assistant professor of surgery at WashU with none other than Dr. Awad. And he specializes in foregut and hernia surgery, so this will be good topics for him. He's going to be reviewing general abdomen, hernia, and spleen questions. Thanks for being with us this evening, Dr. MacGregor.
Thanks for inviting me. Excited to be here and we can get right on started. Let's see it's perfect. There are the questions. So we'll get right on into it. A cachectic 75-year-old man with rheumatoid arthritis being managed with prednisone and methotrexate undergoes an open right hemicolectomy for an obstructing cecal mass. On post-op day 2, a tender bulge appears at the midline laparotomy with some salmon-colored fluid soaking through the dressing. That's noted. What is the next best step in management? So I'll give you a little bit of time. Couple things to key in on when you're reading this. They're obviously giving you specific details of the patient themselves, being on immunosuppression for the rheumatoid arthritis. You're also noting that it's post-op day 2, a new tender bulge, and then they specifically mention the salmon-colored fluid soaking through the dressing. So I think looks like we're probably there. Just wait for the answers. And I guess I should be, reading the answers. So should we get a CT scan of the abdomen pelvis, pan culture, and administer antibiotics, remove staples sterilely at the bedside, exploring the wound in the OR, or reducing the midline bulge? So great job, everybody. Most of you got this right. Wound exploration in the OR. So just thinking of essentially what is going on, the most common things being common, new tender bulge at the midline with salmon-colored fluid. They're worried about a fascial dehiscence. We do key in on that terminology that they use to describe the fluid, so the salmon-colored fluid. So you're worried about that being peritoneal fluid. If you see some more purulent drainage or white, chalky, you're worried about an infection. More bilious drainage, you're worried about a fistula, and then that murky dishwater drainage, more of a necrotizing soft tissue infection. So with a fascial dehiscence, essentially almost all of you got that we need to take this patient to the operating room for exploration. CT scans, if you're kind of unsure the patient's really obese, you can kind of help delineate, but this seemed pretty straightforward. There was no really evidence given in the question stem about worry for infection, so no need to pan culture and antibiotic at this point. If you do think about removing the staples, thinking that it's a fascial dehiscence, that could just unleash the beast and underlying bowel underneath. So would not recommend that. If you truly do think that it's a fascial dehiscence, keep everything inside until you're in the OR. And then obviously if you have an acute fascial dehiscence, reducing that at bedside is not going to really help the issue. So strong work with that one. A 37-year-old male undergoes an elective laparoscopic inguinal hernia repair. During the dissection of the myopectoneal orifice, a small venous bleed is cauterized at the deep inguinal ring at the level of the iliopubic tract. Which of the following nerves is most likely at risk of injury? So keying on, this is a most likely type of question. So you're looking at, with these, I always read kind of every answer. A being ilioinguinal, B being iliohypogastric, genitofemoral, obturator, and femoral. Give a little more time. Obviously, considering important things, you're doing a laparoscopic inguinal hernia repair. And kind of the location that you're dissecting in that. So can probably go ahead with the answer, which everybody or most people got right, the genitofemoral. So the next most likely answer that people gave was the ilioinguinal. So if you think about your triangles, this is very important. So as you can see above your the line between your pubic symphysis and iliac crest, up to the left is your direct space, under that's the femoral. Going with your spermatic vessels is your kind of indirect inguinal hernia, and then just down to the right of that is your triangle of pain. And of course, we always try to avoid the triangle of doom, which contains your iliac vessels. So when you're laparoscopic, looking kind of from the inside of the deep inguinal ring, your genitofemoral nerve kind of gives off that genital branch of the genital femoral nerve. So laparoscopically, that's most likely to be injured there. And then when you're tacking your mesh, if you're doing kind of a preperitoneal repair, you do worry about your lateral femoral cutaneous nerve. So those are the two nerves, the genital femoral and the lateral femoral cutaneous nerves, that you're worried about when you're doing a minimally invasive inguinal hernia repair. Now, the next most answered answer was ilioinguinal. That is one nerve that we are all worried about injuring, but that is through an open approach, because your ilioinguinal nerve you encounter when you are doing an open repair, because it courses between the transversus abdominis and the internal oblique muscles. It kind of emerges kind of superficially in that superficial ring. So ilioinguinal is one that we do worry about, but that's through the open approach. Again, the genital femoral and the lateral femoral cutaneous through the laparoscopic approach. Next question, a 45-year-old male with a history of a right laparoscopic, totally extraperitoneal inguinal hernia repair 6 years ago presents to the clinic with a recurrent right inguinal mass. On exam, the lump is consistent with a recurrent inguinal hernia. It is reducible, but causes him intermittent discomfort. He's otherwise healthy and wants surgical repair. What is the most appropriate next step in management of this patient's symptom or condition? So keys to kind of key in on is that he had a prior right laparoscopic TEP repair, total extraperitoneal, and he comes in with essentially a recurrent bulge. So we'll give you guys a little bit of time, but we might be able to move through this a little bit quicker. So we'll kind of go through the answers there. So do we retry the laparoscopic total extraperitoneal repair? Probably not a good idea, as well as the laparoscopic transabdominal preperitoneal repair. We have a phrase that surgery is hard, and that would just be making hard surgery harder. So the most appropriate answer that all of you got, or most of you got, which is great, is a Lichtenstein repair. That's your tension-free mesh-based repair. The mantra is, if you have a recurrence of an open inguinal hernia repair, try to do it minimally invasive the second go around, and vice versa. If you have a recurrence minimally invasive, either laparoscopic through a total extraperitoneal repair or a transabdominal preperitoneal repair, that a mesh-based repair open is the best way. And of course, when you're looking at should you do a tissue-based repair versus mesh-based repair, we have pretty good data to show that not using mesh increases your risk of recurrence. So something to kind of consider, but I think most of you got that. Now, one of the things that I always have to kind of review and kind of go into my mind, sorry, looking at the question answer, is when you're doing a McVeigh repair, now that we have kind of that answer, that's sewing your conjoint tendon, the internal oblique and transversalis fascia to Cooper's ligament. Whereas the Bassini, that's another name that you'll see going around for a tissue-based repair, is sewing the conjoint tendon to the inguinal ligament. So just those different ones. Sometimes I see those questions on tests. So everybody did a pretty good job. Do it the reverse way with mesh. So next question. Great. 52-year-old male presents to the clinic with a bulge at his umbilicus that had been enlarging for the past 2 months. He denies obstructive symptoms and overlying skin changes, but he does complain of pain. His past medical history is significant for alcohol cirrhosis, but he does not see a primary care physician regularly and is not on any medications. On abdominal exam, he has a fluid wave. There's a 4-centimeter reducible but tender umbilical hernia with thinning of the overlying skin. What's the next best step in the management? So do we refer him to IR for a TIPS procedure? Do we refer him to a tertiary care center and send him right into a liver transplant? Do we proceed to the OR ourselves urgently to fix the hernia and place a peritoneal dialysis catheter? Do we start the patient on some medications and sodium restriction and then do this electively? Or do we form a paracentesis followed by an urgent hernia repair? So we'll give you some time to answer that. And I am very pleased to see the answers there. I always try to refer these to my hernia partners. That is my answer to this. But if I am to do this myself, I agree with most of you that have answered that, in fact, D is the correct answer. So starting the patient on sodium restriction and diuretics. You could see from the question stem that he is an alcoholic cirrhotic, does not follow with a primary care physician, and is on no medication. So he's not actively being treated for his ongoing cirrhosis. The great part about his hernia is that you can reduce it. It's going to come right back because it's just fluid going into an area of weakness. And normally cirrhotics will always have thinning of the overlying skin. So usually we do not go charging into fixing these unless they actually have active drainage or an incarcerated, and you're worried about a strangulated umbilical hernia. So that is the right call to try to medically manage conservative medical management prior to an elective repair. Now, if you were to have to do this emergently, I have done in the past where some people advocate for placements of drains. I do not. I perform serial paracentesis at the same time, kind of as an urgent hernia repair. But the most appropriate thing for him is the medical management. And then eventually he'll need a TIPS, most likely, if that doesn't work. Next one, 56-year-old woman, history of a laparoscopic gastric bypass for obesity, presents to clinic 1 year after a laparoscopic total abdominal colectomy and end ileostomy for C. diff colitis with a painful 5-centimeter parastomal hernia. She reports intermittent nausea and vomiting and averages about 2 liters of ileostomy output per day. She had a gastrograph, an enema, and flex sig that demonstrate an intact 18-centimeter rectal stump. Her current BMI is 32. What is the most appropriate management for this patient? A primary parastomal hernia repair, stoma belt and a binder, parastomal hernia repair with mesh, ileostomy reversal, and a staged parastomal hernia repair, and a stoma relocation and parastomal hernia repair. So a couple things with this is that she appears to be symptomatic. And they key you in on a couple things that we kind of always have our stoma patients kind of go through. She's had a gastrograph and enema and a flex sig showing that she has a pretty good rectal stump, and that kind of plays a role in what the answer is, which appears to be most of you getting to that point. And again, my answer is, did you find the wrong clinic? Go down the hall to one of my hernia partners. But if I have to take care of these, answer D is the safe answer. Now, that's not something that you necessarily may see in practice, but on the AB site, that is the safe answer. So my first question to anybody who comes to me with a parastomal hernia is, can you get the stoma reversed? And I will message the colorectal surgeon or talk to them about that to do that. And so if we can get it reversed, then it becomes just a basic hernia repair. So the ileostomy reversal and then the safe staged parastomal hernia repair kind of a approach. Now, we sometimes will do these at the same time, but again, the staged approach is the safest. If you do have to do parastomal hernia repair techniques, we most often can do them minimally invasive if it's just an isolated defect at the stoma site. You can see here with the pictures, a couple techniques have been described using mesh, a keyhole technique where you kind of cut and make a hole through the mesh through which your stoma can come out, or a sugar baker technique where you kind of have a little bit of overlap and drape the stoma and kind of run it along the lateral sidewall of the abdominal wall from the inside. Studies have shown that overall parastomal hernias are going to come back, but the best repair that we have with the least risk of recurrence is the sugar baker mesh-based technique. So either way, we're sad with parastomal hernias, but if you're going to do one, sugar baker is the way to go. So next one, a father comes to the office explaining that he has a strong family history of a disease related to anemia, and that he is interested in testing his 3-year-old son. On exam, his son has a palpable spleen and spherically shaped erythrocytes on the peripheral smear. His red blood cell count is normal. Which of the following is true regarding this condition? So reading carefully the question, so it's kind of a true-false scenario, so making sure you're carefully reading what the question is asking. So A, the child should have a splenectomy as soon as possible. B, the child should have an ultrasound of the abdomen prior to splenectomy. C, the patient will have a positive Coombs test. This disease is commonly inherited as an autosomal recessive pattern, and then E, splenectomy increases the amount of spectrin in the erythrocyte. So first, it's kind of identifying what you think the disease process is, and then how we treat that. So we'll give a little bit of time. There's a little bit more variability with this one, which is good. But it seems like most people are on the right track. So with kind of going through, the first thing I do with this is, okay, what do I think they're trying to get at from a disease process? And that's hereditary spherocytosis. So with that, it's, if you kind of remember, and I frequently forget, but it's an autosomal dominant disease, and that it leads to kind of deficiency of spectrin in the erythrocytes, and that makes them pretty fragile when they go through the spleen. So they get trapped, the spleen gets big. Other things that happen as a result is patients get anemic, they get reticulocytosis, and then even can develop gallstones, which is kind of the crux of part of this. So to treat this, as you go through the questions, the child should have splenectomy as soon as possible. They recommend that you wait until after year 5 of age to get them removed. This patient was, he was talking about his 3-year-old son. Answer B, we'll kind of come back to. With this spherocytosis, they'll have a negative Coombs test. And then again, we talked about it's an autosomal dominant disease, and splenectomy doesn't increase the amount of spectrin. It just will result in less of the cells getting trapped in the spleen. This kind of alludes to the fact that the patient is more at a higher increase of developing gallstones, which will be pigmented, and often is considered for cholecystectomy at the time of their splenectomy.
Dr. MacGregor, doing great. This is terrific. Sorry to interrupt. Just for the folks in the audience, and I know some of you have kind of raised your hand. Unfortunately, we can't call on people to answer questions live, but again, there is the Q&A feature. You should see that in the menu of Zoom, maybe at the bottom of your screen. And we're monitoring the Q&A, and we can try to answer your questions directly there. Thank you. Sorry, Dr. MacGregor. Thanks.
Okay, no problem. Sorry, going through. Oh, yeah. Okay. A female patient with immune thrombocytopenic purpura has no improvement in her symptoms after maximal medical therapy and is recommended for splenectomy. Which of the following is an absolute contraindication for laparoscopic splenectomy? So these are fun questions because they kind of give you some stuff, and then you could actually disregard the entire first question and look at just the question that they're asking. So which of the following is an absolute contraindication for laparoscopic splenectomy? A, cirrhosis with portal hypertension. B, splenomegaly. C, D, and E, either first, second, or third trimester of pregnancy. So we'll give a little bit of time for that. Again, it's oftentimes as a test taker, I often read the question first, and then I go back to the text to kind of glean in on specific details that I'm looking for based on what I think they're asking. Some people like to read the question from start to finish, so it's kind of your comfort level, but good. We have a little more variability with this one. So laparoscopic splenectomy, I'd say in general is preferred over an open approach, and I think is used more frequently as such. So the absolute contraindications is becoming fewer and fewer, but I would say the first answer, which actually we had a tie for A and E with the group, so that's good. But the first answer, cirrhosis with portal hypertension, is probably one of the ones that I know the most. And the thought behind that is that with patients with cirrhosis and portal hypertension, it increases your risk of having portal vein thrombosis. which could be pretty fatal if all that kind of back flow and increases your risk for bleeding and a worsening ascites and hepatic encephalopathy and all that. Splenomegaly, we often are removing spleens that are big, and you can use techniques to kind of morcellate them to get them out of the abdomen, hand assist techniques as they describe. Obviously, first trimester, we try to avoid just anesthetic risk in the first trimester. So that to me is a close absolute contraindication. But probably not the most absolute contraindication. And the reason for that is to reduce the risk of spontaneous abortion. Second trimester is the safest time of pregnancy to undergo any surgeries. And then the third trimester can also be safe. You just have to be cognizant of your approach, how you're getting into the abdomen, where you're placing your ports, and how you're positioning the patient on the table as well. All right. 57-year-old man presents to the emergency room with complaints of fevers, chills, rigors for the past 2 days. His medical history includes motor vehicle collision 2 years ago that required an emergent laparotomy, splenectomy. He received all the necessary immunizations prior or after being discharged and was subsequently lost to follow-up. The patient becomes progressively septic, and he's evaluated and requires initiation of vasopressors. Which of the following organism is most likely responsible for this patient's condition? And then list said organisms. So this is another one that you kind of have to key on. To me, it feels like a know it or you don't kind of question, and a question that you can kind of see that there are a lot of answers that are true, but this is a question that says most likely responsible. So highest chance of causing this condition. So first of all, you have to identify that condition, which hopefully you all do as post-splenectomy sepsis or infection. And since we've gotten most of the people, you guys nailed this question. You identified correctly strep pneumo. So as you can see, H influenza can also, the one that I learned in reviewing these questions, that capnocytophagia canomorphosis can happen after dog bites. That's fun, but no history of that. So again, just keying in on and kind of knowing strep pneumo most likely. And since most of you nailed that, we can kind of move on. 48-year-old male is admitted to ICU after undergoing emergency laparotomy for multiple small bowel perforation secondary to blunt abdominal trauma. Over the next 12 hours, he becomes progressively oliguric despite fluid resuscitation, and his ventilatory requirements increase. His abdomen appears distended and tense. Intra-abdominal pressure is measured with a transducer attached to a Foley catheter. And after instilling 25 cc's of saline into the bladder, the pressure at end expiration in the supine position is recorded at 24. Which of the following is most appropriate next step in the management? Do we administer a bolus of IV fluids to optimize the organ perfusion? Do we increase sedation and neuromuscular blockade to reduce intra-abdominal pressure? Obtain an urgent CT? Do we do an emergent decompressive laparotomy or place the patient in reverse Trendelenburg to lower the intra-abdominal pressure? And this is one that I think it looks like we can probably move through pretty quickly too. You guys are all keying in on the correct thing to do. So the first thing is to identify, again, what is going on with the patient. And it looks like you guys did that. So abdominal compartment syndrome. I feel like this is tested frequently. So it's a critical condition. It's defined by an intra-abdominal pressure greater than 20 millimeters of mercury associated with new organ dysfunction or failure. So they keyed in on the oliguric aspect and then increase ventilatory requirements, further respiratory failure. And the only treatment for abdominal compartment syndrome, in my eyes, is a decompressive laparotomy, especially in this setting. You do want to make sure that your performing the intra-abdominal pressure measurement correctly, which they kind of described to you, is, making sure the patient is heavily sedated in the supine position. You measure at end expiration, and then instilling that amount of saline into the bladder. And you can see all those, you can read about all the reasons why we get abdominal compartment syndrome, but you guys nailed that question as well. All right, so 54-year-old male presents to your clinic with complaints of postprandial epigastric pain and vomiting shortly after meals. Patient has 50-pound weight loss over the past 8 months and developed a fear of eating. Image studies reveal compression of the third portion of the duodenum by the superior mesenteric artery. Which of the following is the best operative treatment? So this is one that they kind of give you the diagnosis, and you have to know how we treat it. So it's division of the ligament of Treitz. Is it a duodenojejunectomy, a Roux-en-Y gastric bypass, superior mesenteric artery bypass graft, and a Billroth 2 procedure? So you kind of have to think of your anatomy with this, knowing that they're kind of describing the compression of the third part of your duodenum by your SMA, and they want the best approach. They also give you important details that the patient had a 50-pound weight loss over the past 8 months. That kind of makes some of these choices not ideal. So we can probably go, and most of you got appropriately answered this. So a duodenojejunectomy. So SMA syndrome, it's when your third part of your duodenum is compressed between the SMA and the vertebral column. It's mainly, you see it in patients having postprandial epigastric pain and vomiting, and they do have a pretty good amount of weight loss with it. So in kind of going through, like, how do we bypass this area in the third part of your duodenum? And that's through the duodenojejunectomy. To diagnose it, you do want to have either a CT, PO, an IV contrasted study, or an MRA. An upper GI, looking through the entirety of your esophagus, stomach, and through the small bowel. And then an EGD, we also often ask our patients to get that reaches the third part of the duodenum. So if it's acute, if it's severe, sometimes this can be managed with kind of conservative management at first. And you just make sure you try to get a feeding tube distal, you put them on TPN, decompress the proximal system. Obviously, this patient presents 8 months history of weight loss, so kind of failed that management and probably needs something more intensive. So 42-year-old woman presents to the emergency department with abdominal pain. She has no past medical history, but reports stretch marks on her abdomen, weight gain, easy bruising, and recent depression. A 24-hour urine cortisol is elevated. Plasma adrenocorticotropic hormone is depressed. High-dose dexamethasone suppression tests fail to suppress the cortisol level. And a CT scan shows an 11-centimeter right adrenal adenoma without clear flat planes. There's no local or regional lymphadenopathy. What's the best next step in her management? So they give you, so we'll go through the answers: observation, an MRI of the abdomen, a unilateral laparoscopic adrenal resection, open unilateral adrenalectomy, and an open bilateral adrenalectomy. So they kind of give you pretty much straightforward kind of diagnosis, adrenal adenoma, cortical secreting, but they also give you important information. So the size, the 11-centimeter size, that is present without clear fat planes. So we'll give you another moment, but it looks like most of you are keying in on the right answer. So obviously coming in with a cortisol producing adenoma, for most patients who have these with the appropriate size and criteria, a laparoscopic approach is great, but they gave us 2 pretty specific reasons why we don't want to do that. So the size of it, as the adenoma gets larger, it increases your risk of this being something scary like cancer. And they further go with that with saying that there are no clear fat planes around the adenoma. So kind of big red flags showing telling us that there's a higher rate for malignancy. And the answer to this, if you're worried about malignancy, is an open adrenalectomy. It is not appropriate to perform laparoscopic adrenalectomy in that regard. And then last one, 71-year-old woman with liver cirrhosis presents to the hospital complaining of abdominal pain and fevers. Physical exam reveals distended abdomen with remote open appendectomy scar in the right lower quadrant. CT abdomen pelvis demonstrates a moderate amount of ascites without other acute pathology. A diagnostic procedure is planned for the most likely diagnosis. Ultrasound is unavailable. Which of the following is the most appropriate landmarks for this procedure? So we'll kind of wait. So you have patient with cirrhosis, abdominal pain, fevers, and a moderate amount of ascites. So hopefully you guys are keen in on the diagnosis here. Give you a little bit more time. Unfortunately, you can't use ultrasound. So where are we going to try? I think we could probably go ahead. Most people are kind of keying in on. So you need to essentially get a safe space to get a diagnosis or aspirate of a sample. So hopefully you guys all kind of identified we're worried about spontaneous bacterial peritonitis, and you need a diagnostic paracentesis to do this. And honestly, I see this as kind of have to know how the procedure is done to perform, but most of you were able to identify that the safest place to do this is 3 centimeters medial and superior to the left anterior superior iliac spine to avoid kind of other underlying organs and places that you want to avoid trauma. And for patients at high risk of having, splenomegaly and other complications.
Dr. MacGregor, that was phenomenal. We really appreciate you joining us this year for a terrific overview of that ABSITE topic. Really appreciate your time and expertise. Phenomenal. Thank you.
Thank you.
All right, and we're going to go ahead and transition to the next topic in this, and it is my distinct pleasure to welcome Dr. Pat Sylla. Dr. Sylla is the System Chief for Colon and Rectal Surgery Mount Sinai in New York, and is importantly a very recent past president of SAGES. So we're very grateful for her time and honored for her to be here today. She's going to lead us through the discussion of colorectal and anal disease, and those questions are coming up here momentarily.
Perfect. Hi, everyone. Hopefully you're still feeling sharp and able. All right, we're going to start. Okay, there you go. So first question, you have a 61-year-old male found to have rectal bleeding 2 days after an open AAA repair. On exam, he's febrile, has abdominal tenderness and distension. His white count is mildly elevated, but he remains hemodynamically stable. And the question is, what is the best next step to manage this patient? Urgent CT scan of the abdomen pelvis with oral and rectal contrast, serial abdominal exams, sigmoidoscopy, abdominal x-ray, or emergent exploration. I'm starting to see how the numbers shape up. So obviously the key is you have to already know where they're leading you. This is a potential dramatic catastrophic complication of open AAA or endovascular even AAA. If you don't know the anatomy, the risks associated with the open AAA repair for the gut. All right. Almost. It started pretty good. Just 47% of you got it right. So this is important. You have to know that. The risk here is essentially ligation of the IMA during the procedure. And if the patient doesn't have good collateral flow to the left colon and sigmoid, essentially you're going to have critical ischemia. So this is a patient that you have to worry about as an ischemic event of the colon. And it already tells you the patient is stable, however, is already having a fever and some abdominal pain. So you don't have much time. Time here is of the essence. So CT scan sounds reasonable, except that it's going to take too long. Even an urgent CT scan will take too long to get a diagnosis. Serial abdominal exams are not sensitive enough. X-ray will pick up pneumoperitoneum possibly, but again, will delay the therapeutic management of this patient. Immersion re-exploration, there's still a chance you can treat this conservatively if it's not a severe necrosis of the colon. So the answer is C, sigmoidoscopy. You want to take to the patient at the bedside. That can be done in the ICU. In a patient bedside is to perform a sigmoidoscopy to evaluate the degree of ischemia. If you're lucky and you get there early enough, it's just the mucosa will be involved, will be ischemic. But if it's already advanced, it will be full thickness ischemia with necrosis, and that will warrant immediate return to the operating room to deal with it. So that's why sigmoidoscopy is something that you really need to know. Okay, next question. 83-year-old with Alzheimer's dementia presents to the emergency department because of acute perineal pain. The physical exam shows protrusion of the rectal mucosa with edematous concentric folds. It is friable, ulcerated, dark in appearance, and cannot be reduced in the emergency department. Which of the following is the most appropriate next step in the management of this patient? A, application of sugar and attempted manual reduction. B, mucosal sleeve resection or Delorme procedure. C, perineal rectosigmoidectomy or Altmaier procedure. D, manual reduction under general anesthesia and transabdominal rectopexy or transabdominal resection rectopexy. So you have all the key giveaway. Obviously, anything sticking out of the butt, okay, is either hemorrhoids or rectal prolapse, okay? So, and here they give you all the cues. This is concentric folds really gives it away. It's full thickness protrusion of the rectum. So that's rectal prolapse. And yes, A would be, I'll show you the explanation. There you go. So you, very good. So 73% of you got it right. So this is pretty dramatic. Your pictures here show you the story here of full thickness rectal prolapse. But again, it's unfortunately strangulated at this point. So got there too late, cannot manually reduce it, cannot apply sugar and try to reduce it either at the bedside or in the operating room. At this point, the treatment is to resect because it's presumably dead. So it's a rectosigmoidectomy or Altmaier procedure, which is a full thickness resection with Hanson colloidal anastomosis. So the other options are not safe. Delorme is a muscular plication of the rectal wall to secure it back in place, and that's not appropriate here. And all of the other options, which is rectal prolapse repair in the elective setting, are not appropriate in this emergency setting. So good job, 73% success. Excellent. Next question. A 45-year-old man presents to the surgery clinic with a 6-month history of anal pain, bleeding, and copious mucus discharge. The physical examination reveals a shallow ulcer with a punched-out gray-white base surrounded by hyperemia on the anterior rectal wall just above the anal ring. Which of the following is correct regarding this patient's most likely condition? A, this condition is always present as a single ulcer. Whenever you say always, always be suspicious, right? B, biopsy is not usually indicated due to the benign nature of this condition. C, this condition most commonly occurs at about 15 centimeters from the dentate line or above the dentate line. D, infection is the most common underlying etiology. And E, conservative treatment should be tried first. That's a tough one, by the way. Even our colorectal fellows may get it wrong, so don't feel bad if you struggle with this. This is one of those things that you just have to memorize. We see it maybe once or twice a year in the colorectal practice. So this is a tough one. All right. I think we're seeing, yeah, so 31%. I know this was tough. So this is what we call a solitary rectal ulcer syndrome. And unfortunately, solitary is a misnomer because they usually occur in multiple places, typically on the anterior rectal wall, but unfortunately, it's never a single ulcer. It can be multiple. Biopsy is always a good idea when you have an ulcer because you have to rule out infectious etiologies, including STDs and other pathology, including cancer. So biopsy is never wrong. This condition most commonly occurs at 15 centimeters. That's not true. It's something that actually is just above the anal rectal ring, so usually about 4 centimeters from the anal verge. Infection is the most common. That is not true. We actually don't really know the etiology. We know it presents most commonly in people with a history of constipation. Severe straining can lead to intussusception or even rectal prolapse. These patients typically have pain and are really uncomfortable and do require some biofeedback to treat them. But we usually start with conservative treatment. That's really the standard of care. After you've biopsied it, you essentially put them on fiber, laxative, and biofeedback can be very helpful for patients with pelvic floor dysfunction who just cannot evacuate properly. So it's one of those things that unfortunately you just have to memorize for the solitary rectal ulcer syndrome. Okay, next question is 57-year-old woman is found to have rectal cancer on colonoscopy, and she gets staging CT scan, which is negative for metastatic disease. A pelvic MRI reveals invasion of the muscularis propria. That's important for you to know exactly what the T stage is without nodal disease. She undergoes a laparoscopic colorectal resection with a total mesorectal excision, or TME, with colorectal anastomosis. She recovers well, presents for her first post-op visit. The final path shows a well-differentiated upper rectal cancer with invasion of the muscularis propria, but no invasion of the mesorectum. There is no lymphovascular or nodal involvement. The margins are negative. Which of the following is the most appropriate management of this patient? A, routine surveillance. B, adjuvant chemotherapy alone. C, adjuvant radiation alone. C, adjuvant chemoradiation. E, immunotherapy. I'm loving how the answers are shaping up. This is a great question to test your knowledge about staging, and then how then, based on staging, final pathology, how this patient should be treated subsequently. So this is a classic. Important to note that staging is both CT and MRI. Looking, almost 50% of you got it right. Okay, this is important. So it tells you both on preoperative staging and on pathology is confirmed to be a T2. So it invades into the musculus propria, but doesn't go through it. So it's not a T3. It's a T2, N0, M0. So there's no metastatic or nodal involvement. That makes it a stage 1. Stage 1 is either T1 or T2 N0 disease. A stage 1 rectal cancer, essentially that's been entirely resected, presumably tells you that the surgery went very well. There's negative margins. Presumably the TME is intact. There's no high-risk features. So this is somebody who should just essentially undergo routine surveillance. And so even when you see adjuvant chemotherapy alone, without nodal disease, it's not indicated. Chemoradiation as well. Immunotherapy, this is not relevant here. This is it doesn't tell you anything other than a standard adenocarcinoma. There's no reason to suspect anything else. So routine surveillance, which consists in colonoscopy, essentially 1 year, and pretty much NCCN guidelines based. So that is important for you to know how to manage a stage 1 rectal cancer. Next question is a 30-year-old, otherwise asymptomatic man is seen in by his primary care physician for a pre-work physical examination. He personally has no history of change. He personally has no history of change in bowel habits, IBD, or previous colonoscopy. Questions regarding his family history reveal that his father was diagnosed with colon cancer at the age of 59. What is the current recommended colorectal screening for this patient per NCCN guidelines? Colonoscopy beginning at the age of 40 and repeated every 5 years if normal. Colonoscopy beginning at the age of 40 and repeated every 10 years if normal. Colonoscopy starting at 50 and repeated every 5 years if normal. Or starting at the age of 52 and repeated every 5 years if normal. Or yearly fecal occult blood testing with flexible sigmoidoscopy every 10 years, beginning at the age of 50. This is important. This is screening in the United States as it's done based on the latest recommendations in a patient with a first-degree relative with colon cancer. Looking good. The majority of you has the answer right.
Pat, are you seeing the poll? We're having some issues on
It
our
kind of
end.
it was going and then it froze, it looks like.
Okay. It's saying invalid poll ID, so I think Betty might have to reset it.
Oh.
So if you want to just
Yeah,
we can just
but
answer
at
this
least
question.
when it froze, it was at 48%. So at least already 40% of you guys got it right. So yes, the recommendation is if without any risk factor, without family history, the recommendation would be starting at 45, and then every 10 years if the colonoscopy is normal. So without any high risk features. But here, this is a patient with a first degree relative, cancer at 59. So the recommendation is 10 years before the age at which your first degree relative was diagnosed, or 40, whichever is younger. So in this case, at 40, he should get his colonoscopy, and it should be repeated every 5 years. You can't afford to wait 10 years in somebody with a first degree relative and that type of potential risk. All the other answers obviously are wrong because they don't even mention 45. Even if you didn't have any risk factors, the answer is not 40 or 50. And so that is a given. So this is something that you should definitely memorize those recommendations. Okay, a 52-year-old female found to have a 3 centimeter descending colon mass. Biopsy proved adenocarcinoma and associated with a 3 millimeter liver lesion, highly suspicious for metastatic colon cancer. She's scheduled for a synchronous resection of the liver and left hemicolectomy. What is the most sensitive test? Most sensitive test to identify other liver lesions. Intraoperative physical exam, intraoperative ultrasound, four-phase CT, dedicated MRI, right upper quadrant ultrasound. So here, this is really a matter of understanding this is in the operating room. She's scheduled for surgery. And what is the best approach to identify other lesions at that time? Are we still frozen? I don't see anything moving on the right side.
Yeah, we're still frozen. Betty's trying to
Okay.
Working
It's
now.
live again.
Yeah, it's working.
Perfect. Yeah, so far so good. You guys are definitely heading in the right direction. So there's no question that, in the real world would start with a CT and MRI preoperatively, but I think they're trying to make you understand that the best test for detecting smaller lesions, especially in the 2 to 5 millimeter range, is. Can you show the explanation now? Because I think the group, 72% of you got it right. The best strategy to really identify potential occult smaller lesion, especially in the vicinity of 2 to 5 millimeters, is an intraoperative ultrasound. It's very, very sensitive, more sensitive than a CT scan or MRI. So this is really a great tool in the OR to identify smaller unsuspected lesions. Okay, next question. A 64-year-old man presents with severe abdominal pain. He's noticed blood in his stool and smaller stool caliber over the last year. He's never had a colonoscopy before. CT scan of the chest, abdomen, pelvis shows moderate pneumoperitoneum and suspicion of it for an obstructing descending colon mass. There are no other lesions. His CEA is elevated. He's taken to the OR intraoperatively, normothemic, normotensive, off pressors. There's minimal intra-abdominal contamination. The surrounding colon appears viable and healthy. They're giving a really good details about what's happening in the OR here. What is the best management for this patient? Left hemicolectomy with a post-op colonoscopy within 1 year of surgery. Diverting loop transverse colostomy with a post-op colonoscopy within 1 year of surgery. A left hemicolectomy with a post-op colonoscopy within 3 to 6 months of surgery. Diverting loop transverse colostomy with a post-op colonoscopy within 6 months of surgery, and a left hemicolectomy with complete intraoperative colonoscopy in unprepped bowel. Good luck with that. Okay. So you have to pay attention to the scenario. So this is clearly a patient, unfortunately, a very common scenario of somebody who comes in with an obstructing colon cancer. And so a left-sided colon cancer, which is the most common location for these obstructing tumors, unfortunately. And so how do you deal with this when the patient clearly needs an operation? And it's looking very good. I think you guys are right on it. Exactly. So most importantly is they're giving you the scenario that there's no contamination, the bowel looks good, even though they're unprepped. This is your chance to still be able to do the right thing, which is a oncologic resection. So the idea is, yes, you try to resect it and follow oncologic principles and try to put them together. No role for diverting and getting out or bailing out. So you want to take it on, resect, do the best you can, put them back together. And so this is really the left hemicolectomy is the only good answer. But with that, you have to think about what you do next in terms of screening the rest of the colon. And so 1 year is not acceptable. So the recommendation is within 3 to 6 months, the patient have a proper colonoscopy to assess for any potential additional lesions, either cancerous or precancerous. So this is really the right answer. And intraoperative colonoscopy obviously would be great, but very unpractical in a setting of unprepped bowel. Good job, guys. 68%. A 32-year-old woman presents with a newly diagnosed colon adenocarcinoma that was found on workup of chronic iron deficiency anemia, unintentional weight loss, and small caliber stools. Family's history, and she's 32. The patient's family history includes her mother diagnosed with colorectal cancer at 43, a maternal grandfather diagnosis of colorectal cancer at 55, Additionally, her sister was diagnosed with endometrial cancer at 35, and her brother was recently found to have hundreds of polyps in his colon. Hundreds. Given the patient's family history, which of the following conditions is consistent with the patient's presentation and familial pattern? Coden syndrome, Lynch syndrome, FAP, or familial adenomatous polyposis, Post-Jager's syndrome, or juvenile polyposis syndrome. You guys should have that nailed down just from the hundreds of polyps in the colon and all the other associated features that you find in autosomal dominant conditions, right? Seventy 70% of you. Excellent. That is classic FAP, APC mutation. Okay. So you have all the giveaways, all generations are involved, multiple cancers, not just colorectal cancer, but also potential gastric and endometrial ovarian. And of course, a giveaway is really the hundreds of polyps, which is typical for FAP. The others have polyposis syndromes associated with them. Cowden as hematomas, Post-Jager's have fewer polyps. So does the juvenile polyposis syndrome. But really, the classic hundreds to thousands of polyps is in a setting of FAP. So that is the giveaway here. Okay, next. A 50-year-old undergoes laparoscopic right colectomy for colon cancer. During his hospital course, he's diagnosed with pneumonia and he started on IV antibiotics. On post-update 10, he develops frequent watery diarrhea. Testing reveals that he's positive for C. difficile. He is tolerating a regular diet and otherwise recovering appropriately. Okay, after discontinuing his IV antibiotics, what's the next line treatment should be started? PO flagyl or metronidazole, IV metronidazole, PO vancomycin, PO fidaxomicin, or rectal vancomycin. That's another one that you just have to know. And this is interesting because that changed from my time, right, Mike? Just a couple of years ago, it was not that. So you have to know the latest recommendations for the treatment of initial uncomplicated, so not fulminant C. diff colitis. Okay?
Indeed. Indeed.
Yeah, it used to be. I'll talk about this. How are we doing here? 50%? Oof. So maybe it's people like me who were answering PO flagyl was the answer for initial non-complicated initial C. diff episode, but no, the recommendations have changed now. In that scenario, the first line is fidaxomicin. You just have to memorize it. Alternatively, you can give Vanco, but it's really fidaxomicin has been shown to be superior and more effective than oral Vanco. So you just got to know it. You have here the description for what you do in fulminant disease is PO Vanco, IV flagyl, and even PR per rectum vancomycin enemas. And then you have the recurrence protocol also is phytomaxin is still first line. So yeah, things have changed. This has been changed since 2021, so it's actually relatively recent. So yeah, phytomaxin is the fidaxomicin is the answer. All right, 39-year-old female with Crohn's disease and pathological history of bowel resection for stricture, present with abdominal pain, bloating, and obstipation. She has been optimized on medical therapy. She's stable hemodynamically. Her CT scan reveals a stricture in the sigmoid colon with partial fecalization of the small bowel content. There are no other areas of stricture and no perianal disease. These are important pertinent negatives. The rest of her colon is of normal caliber. What is your appropriate definitive treatment of this stricture? Total abdominal colectomy with ileorectal anastomosis, ileocolonic bypass, a left colectomy with primary anastomosis, total proctocolectomy with ileal pouch anal anastomosis or IPAA, or J pouch, or segmental colectomy. That's an excellent question to test your understanding of the surgical treatment of Crohn's, isolated Crohn's disease. Okay, lots of pertinent negative here. How are we doing? Ooh, very good. Okay, segmental colectomy. Actually, when I first saw that, I said left colectomy, but I realized what they really want to get at is that you're really just targeting the stricture because the patient has no evidence of Crohn's anywhere else in the colon. There's no reason to do a more extensive resection. You just want to do a limited resection to take care of the problem at hand and save as much bowel as possible. That's really the concept for Crohn's in general. But in this case, there's really no reason to take out a whole colon or do anything else for that matter. You just want to resect that segment and put it back together. So excellent answer. And there's no perineal disease or anything else that would preclude putting her back together. So excellent answer. Next question. A 54-year-old man with multiple comorbidities undergoes a laparoscopic colectomy with primary anastomosis for a previous episode of diverticulitis. The procedure proceeds without complications with following enhanced recovery. Oh, which of the following ERAS or enhanced recovery protocol components for the patient-specific procedure is supported by the best level of evidence? This is a tough one. One, carbohydrate loading should be encouraged in non-diabetic patients preoperatively. B, mechanical bowel preparation with oral antibiotics preparation decreases complication rates. 3, preset orders should be part of an enhanced recovery pathway. D, a clear liquid diet may be continued up to 2 hours prior to general anesthesia. And E, thoracic epidural anesthesia should be used routinely after laparoscopic colon resections. So that's a tough one because it kind of forces you to kind of know that publication, the paper published by Haskins and Sages. This is something you should probably put as your reference article that you should look at for all the elements of the ERAS protocol. And the strength of the recommendation is based on a level of evidence to support those recommendations. So it pushes you a little bit to really know your stuff here. So, I know. I got it wrong too the first time, guys. I have to admit. So, no shame here. And this is tough because there's really only one wrong answer. All the others are actually recommendations in the paper, in the clinical guidelines. The only one that is not true is a thoracic epidural anesthesia. That is not true. Should not be used routinely, only for open surgery typically. And so that is an incorrect answer. But everything else is part of the ERAS protocol. It has to do with the strength of the evidence. And the only one here that has the best or the high level of evidence is a clear liquid diet that may be discontinued until 2 hours prior to general anesthesia. That's based on actual good quality data, like probably RCT, if not the next best thing. All the other recommendations have weak evidence to support them. Okay, so that's one you have to know has been tested, has been proven, and that's why it has the highest level of endorsement by the societies. Okay, 27-year-old female patient is newly diagnosed with a right-sided colon mass suspicious for adenocarcinoma. The patient's grandparent, mother, 30-year-old sister have significant cancer histories. Genetic testing reveals no mutation of the APC gene. Oh, they just give it to you, right? It's not an APC gene mutation. What genetic syndromes is likely represented in this presentation? Okay. Lynch syndrome, juvenile polyposis, Pasch-Jaeger syndrome, FAP, or MUTYH associated polyposis. Right, definitely not D. It's been established. But the others, I think they're pushing you to really learn the features associated with the Amsterdam 2 criteria for Lynch syndrome. You guys already knew that. 87. Fantastic. Love it. Short explanation. Exactly. So Lynch, so the Amsterdam criteria are pretty classic. One cancer, Lynch related before the age of 50, that's the patient in question. 2 or more generations, that's exactly what's happening. And then 3 or more relatives with cancer, and one of them is a relative of the other 2, first degree relative of the other 2, so that's exactly the case. And FAP has been ruled out. So there you go. That's a classic Amsterdam 2 criteria right there. All the others don't fit in the picture. A 62-year-old man presents to the outpatient surgery clinic with a complaint of persistent anal itching. He was treated 5 years ago with a combination of chemotherapy and radiation for squamous cell cancer of the anal canal. He's otherwise healthy. On clinical exam and subsequent biopsy, he is unfortunately found to have a recurrent disease involving the anal sphincter. CT scan of the chest, abdomen, and pelvis shows no distant metastasis. Which of the following is the most appropriate treatment for this patient? A, observation with frequent biopsies and physical examination. B, radiation therapy alone. C, chemotherapy and radiation therapy. D is low anterior resection, and E is an APR, abdominal perineal resection. That is a pretty straightforward one. Unfortunately, rare to have recurrent anal cell SCC. But unfortunately, yeah, so it's 80%. That's a pretty obvious one. So there's no role for observation. This is obviously oncologic resection is absolutely required in this recurrence. You cannot repeat the chemoradiation therapy. It's already been given. So there's no role for adjuvant therapy here, unless maybe in a palliative setting. But this is not a palliative setting here. This is a patient that you intend to achieve complete remission. So APR, unfortunately, is the only possibility because the sphincters are involved. And this is anal origin of this cancer. So good job there, 79%. Excellent work.
All right. Thank you so much for bearing with us through those IT difficulties. And thank you, Dr. Sylla, for getting us through the colorectal and anal questions. Last but certainly not least is Dr. Shanley Deal. Dr. Deal is a general and bariatric surgeon, as well as the associate program director for the general surgery residency at Virginia Mason in Washington. She has a particular interest in trainee education, and she has done a fantastic job in previous years closing us out for this webinar. So welcome back. We're happy to have you. Dr. Deal will be reviewing small intestine, biliary disease, and flexible endoscopy questions.
All right, thanks everybody. It's been a great session so far. These are always so fun to hear about how other people think through questions as well. So I always learn a lot too. But we're going to dive right in because I'm the closer from the West Coast. So let's start with this first question. We have a 49-year-old woman who presents to the emergency department with severe abdominal pain, fever, and jaundice. She is noted to be hypotensive and tachycardic with right upper quadrant abdominal tenderness. Right upper quadrant ultrasound shows a common bile duct with a diameter of 8 millimeters. After adequate resuscitation, she's taken to the GI endoscopy suite. Which of the following is correct regarding the endoscopic anatomy of the appropriate management strategy for this patient's pathology? So this is really asking you about the location and anatomic verbiage that's relevant for ERCP. So I'll give you guys a couple more seconds there to look at these, but it's going to come down to how well you know your side viewing scope anatomy. All right, looks like we've got a bunch of you weighing in. And there's even a little trick answer in here to throw you off as well. Okay, let's show our explanation. So the correct answer is B, which most of you got. It's still a tricky question though. And so what you need to think about is knowing that the pancreatic duct joins the duodenal papilla at the 3 o'clock position in the ampulla. And there's a great picture on this explanation, which I actually really like because it shows that side viewing endoscope going down and then looking at that view from an endoscopic perspective. And that pancreatic duct is going to be somewhere between 1 and 3 o'clock. And then your common bile duct is more towards 11 o'clock or so. And the ampulla levator is that. So they're kind of tricking you a little bit by including that there. And then the other questions that are, the other answers that are wrong in this case are, less frequently answered on here, which is the common bile duct joins the duodenal papilla at 7 o'clock. We know that that's not anatomically correct. The pancreatic duct orifice joins the papilla at the 6 o'clock position in the ampulla, also incorrect in terms of anatomic orientation. You really just kind of have to memorize this picture and review your anatomy and think about it from an endoscopic perspective. Let's do our next question. These are kind of my highlights for that one. Okay, this is a great one. So you've got a 3-year-old who presents with 6 hours after a witnessed ingestion of a nickel. The child is well appearing, tolerating secretions, and is not in respiratory distress. You do a chest radiograph on arrival, which demonstrates a coin-shaped foreign body lodged in the distal esophagus at the gastroesophageal junction. A repeat chest x-ray performed 12 hours later shows the foreign body is still in the exact same location with no evidence of distal progression. The patient continues to be asymptomatic and without signs of perforation or airway compromise. What is the most appropriate next step in management? So for these answer choices, you've got direct laryngoscopy under general anesthesia, exploratory laparotomy under general anesthesia, observation, so just continue what you've been doing, flexible endoscopy under conscious sedation, or flexible endoscopy under general anesthesia. And you guys have already started responding, which is great. The majority of you got this one right off the bat. And really the key is, who is your patient? You have a 3-year-old, so how are you going to best perform a procedure in a 3-year-old with an object that has failed to progress after 12 hours of observation? So let's show our explanation. And I did give it away a little bit with that kind of preamble, but you can see here on the imaging that nickel is in the upper esophagus there. And then on the endoscopic view, they're showing what it might look like to see a coin in the distal esophagus. The picture doesn't quite add up with their paragraph explanation, but overall, you're really going to need general anesthesia for a 3-year-old to get them calm and still enough to perform a flexible endoscopy to extract that nickel. Observation is really not recommended because there could be pressure and ischemic changes if you leave that object lodged there longer than 12 hours. So most recommendations do not recommend continued observation, and there's no way to know for sure it was a nickel. So if there could be a caustic object, it's really important to get that out when it hasn't passed on its own. Okay, let's do our next question. You have a 60-year-old man with a history of Crohn's disease and no prior surgery who's undergoing a colonoscopy for disease monitoring. He has a redundant colon and areas of stricture that make the colonoscopy challenging. Which of the following is the most definitive way to confirm the completion of the insertion process in this patient? At least 100 centimeters of scope inserted, hubbing the colonoscope with the anus, visualization of the appendiceal orifice, intubation of the terminal ileum, or visualization of a blind end of mucosa. So those are your options. Looks like most of you are weighing in on the 2 most common that I would see people get down to. It's a pretty quick process of elimination here. Most of you are looking at C or D. And the key is to think about what is the specific question. So you can show the explanation now. And for this patient, we want to know completion of the entire colonoscopy. And that can really only be definitively determined if you're in the terminal ileum. If you see the appendiceal orifice, then you've at least done cecal intubation, which is the quality standard that's desired to be over 90% when looking at colonoscopy performance. But if we want to fully screen the entire colon, the only way you can know you've done that for sure is if you intubate the terminal ileum. And then for Crohn's patients, it's actually even more important to be able to assess the terminal ileum as well. So in this case, that's really what they're getting after is, can you put those 2 things together for the question? The other 3 I think are kind of obviously wrong, but that fine difference between C and D I went over. Visualization of the appendiceal orifice does help confirm cecal intubation, but it is not the most definitive way to confirm completion of the colonoscopy when you're doing screening. And you could potentially confuse the appendiceal orifice for a colonic diverticula or some other aberrant anatomy that looked like that. Next question. Which of the following is true of enterohepatic circulation? This is a fun one, getting back to some science. Conjugated bile acids are absorbed in the colon. Approximately 50% of bile acids are excreted in the stool with each cycle of enterohepatic circulation. The majority of bile acids are absorbed by active transport in the jejunum. Poor absorption of bile acids leads to vitamin B deficiency, or primary bile acids are conjugated in hepatocytes with glycine and taurine. You guys are responding quickly on there. There's a couple on here that are pretty easy to eliminate if you remember your pathophysiology well and enterohepatic circulation, and then it gets down to the nitty-gritty and whether you know the details. So let's show the explanation and we'll walk through that. Okay. So the answer is E. Primary bile acids are conjugated in hepatocytes with glycine and taurine. And for this one, it's really helpful if you have a question like this to read through the entire explanation really well, just to brush up on that so that you can kind of lock in some of those key features that are commonly tested. For example, with D, poor absorption of bile acids leads to vitamin B deficiency. It's actually the explanation here. Bile acids play a major role in the absorption of lipids and fat-soluble vitamins. So that kind of reminds you that those A, D, E, K vitamins are what are critical with bile acids rather than vitamin B, which you could get confused by. And so reading through each of those is helpful when you're doing something like this. Conjugated bile acids are absorbed in the colon. That's not true. They're all in the terminal ileum. So just kind of brushing up on some of those gut physiology components before your exam is really helpful for questions like this. A 52-year-old woman presents to her primary care physician with intermittent abdominal pain, hot flashes, and diarrhea. Her history is significant for lap appy in childhood and hypertension. Her physical exam is significant only for mild generalized abdominal pain without rebound or guarding. After an extensive workup, her 5-HIAA in a 24-hour urine sample is found to be elevated. A diagnostic colonoscopy is unremarkable. Which of the following is the most likely location of the neoplastic process in question for this specific patient? So for this one, you need to kind of read through that question stem, think about what they're getting at, know that the diagnostic colonoscopy was already unremarkable. So where would you find this? Let's show the explanation. Most of you have weighed in. So with screening colonoscopy, the rectum has really replaced the small intestine as the most common location for NETs, but the question stem tells you that the colonoscopy was negative. So then you're trying to think of, well, what's the second most common location to find a GI tract NET? And they show you the distribution of carcinoid tumors according to surveillance epidemiology there in the explanation. And so small intestine is the second most common. So they're asking you to identify that. And within the small intestine, the ileum is still the most common location to find a neuroendocrine tumor, specifically a carcinoid. Okay, let's do the next one. An 82-year-old man with a history of multiple blistering sunburns presents to the emergency department with a 4-day history of nausea and vomiting and obstipation. He has a CT scan that shows a large obstructing colon mass at the ileocecal valve and proximal dilation of the small bowel and distal colonic decompression. When inspecting his skin, a large black asymmetric lesion with an irregular border on the right shoulder is noticed. What is the most likely location in the GI tract for this lesion to metastasize? So they're asking you to figure out what it is based on the question stem. What kind of lesion do you think it is, and where is it going to metastasize most commonly? This is one of those MCC questions. All right, let's show our explanation here. So if you followed that well, you would have guessed that this is a cutaneous melanoma. And the most common site of metastases are the lymph nodes and lungs. And so the GI tract is second only to the lung and lymph nodes. The frequency of metastases are the liver, small bowel, colon, stomach, esophagus, and anus, and they kind of lay it out here. And so from the question choices that we have, the small intestinal involvement is the correct answer, and is seen very commonly in patients dying of malignant melanoma. So that kind of helps you eliminate all of the other choices. And you guys did great with that. So you certainly know your most common for melanoma here. Next. A 55-year-old man presents to the emergency room with a 5-day history of abdominal pain and distension. CT scan shows a 5-centimeter mass in the jejunum causing an obstruction. The mass is removed surgically and sent to pathology, where the specimen is found to be c-KIT positive. Which of the following is true concerning this disease? This is one of my favorite questions. I went to OHSU, which is where this was discovered, and they hammered this into us in medical school. The tumor needs resection with 2-centimeter margins. There's no benefit to performing a lymph node dissection with the resection. The tumor originates from goblet cells of the intestine. Most common site of metastasis is the lung. Thymoglobulin can be used to treat unresectable tumors. Show explanation. I think you guys are pretty good on this one. Seeing a pretty good response here. Great. So GI stromal tumors require grossly negative margins. So there's no benefit to performing a lymph node dissection with the resection. And then the c-KIT positivity helps you determine if there's any benefit to adjuvant imatinib. And they tried to throw you off with E by adding in thymoglobulin, but really what they should have put there was imatinib for the additional questions. Next. All right, a 65-year-old man with a history of colon cancer presents to his PCP with a history of epigastric discomfort after eating. He's otherwise asymptomatic. He denies weight loss. His physical exam's unremarkable. Right upper quadrant ultrasound is negative, and he is referred for an upper endoscopy. This demonstrates a 1-centimeter sessile polyp in the first portion of the duodenum. Biopsy shows finger-like projections with dysplastic epithelium. So they've described this really well. Which of the following is true regarding this type of lesion? There is approximately a 40% chance of malignancy. This is a benign proliferation of Brunner glands. The most common location for the lesion is the jejunum. This lesion has a low likelihood to undergo malignant transformation, or they are asymptomatic. All right, you guys have done well with this too. Let's show our explanation. So there are really three main types of small intestinal adenomas. And so the description is getting at this being a villus adenoma. And villus adenomas carry the highest risk for malignancy. It's also really helpful if you're reading through questions like this where they show you a picture to kind of use that picture to help educate yourself for future questions where they might show you a picture and you have to glean that it's a villus adenoma based on that rather than a description. And so in this case, that's what they're trying to get at. And because it does have a high chance of malignancy, that's the correct answer. The other ones are incorrect for that reason. And they can be symptomatic. All right. Now we have a 65-year-old man with no known medical history who presents to the emergency department with altered mental status, jaundice, and ascites. His lab evaluation shows a sodium of 130, creatinine 4.1, BUN of 60, ALT 1500, AST 1600, INR 2.1. From his medical record, lab values from an unrelated visit a few months ago were within normal limits. So these are new changes. His family can't be reached to provide more information. In the United States, what is the most likely cause of this patient's presentation? Acetaminophen overdose, alcoholic hepatitis, hepatitis B, hepatitis C, or idiopathic liver failure? You guys are rocking this question. We'll be quick on this one. Show explanation. So this is acetaminophen overdose. In the United States, that is the most common. It would be tempting to answer alcoholic, but Tylenol overdoses still overpower alcoholic hepatitis for acute liver failure. And it is really helpful when you get a question like this to go over hepatorenal syndrome and liver disease and to brush up on that process so that you know what to watch out for with lab value changes. But they're really getting at what's the most common reason for this particular question. And so the other ones are just not as common, but something to be thinking about in your differential diagnosis. Okay. A 40-year-old woman with a history of heroin and alcohol abuse and a family history of colon cancer presents to the emergency department with chronic vague abdominal pain. A contrast-enhanced MRI is obtained and select images are shown below. What is the most likely diagnosis? These are great questions, and it really gets down to just truly memorizing what imaging findings you should look for with liver lesions and lock those in before your test taking day and for board exams. So A, intrahepatic cholangio, B, hepatic adenoma, C, colorectal liver met, D, hemangioma, or E, HCC. And you can see in the first image, you've got this, early enhancement. It looks pretty homogeneous. It looks similar in B to the liver. And then you've got this washout with a little bit of peripheral enhancement. So if some of those trigger your memory for what this is, that might be helpful. Let's show our explanation and walk through this one. So the correct answer is, sorry, I'm just making sure I show you. Yeah, there you go. I think further down they had this awesome image. There you go. They just have the contrast enhanced sectional imaging table. That one's really helpful to remember, but it's HCC. And I like that they kind of call out and underline some of the things that are important to know about HCC. So arterial non-rim hyperenhancement during arterial phase. So I kind of told you guys, you can see the arterial phase is lighting up right away. And then it kind of slowly starts to wash out. And then in the portal venous phase, you get that kind of peripheral enhancement. It almost looks like a pseudocapsule that can be present on delayed phase. And so these three images really highlight that well. Whereas with an adenoma, you're going to get arterial enhancement and iso-intense to surrounding liver parenchyma on liver images. So it stays bright, stays really well lit up. And sometimes you'll see rupture or hemorrhage in those versus HCC, you usually don't see that. Okay, we're up to our last one. I caught us up. So a 55-year-old man with a past medical history of child-pugh A cirrhosis due to Hep B and a MELD score of 13 is seen in the surgical clinic after being diagnosed with HCC. He has developed 2 tumors measuring 3 centimeters and 2.5 centimeters on the right lobe of the liver, and one that measures 2.5 centimeters on the left lobe. So he has a total of 3 lesions. Staging scans are negative for distant Mets, and there's no vascular or extrahepatic invasion. So they've given you these special clues. The most appropriate next step in management is liver resection, sorafenib, liver transplant, microwave ablation, RFA ablation. You guys are crushing this last question for the finale of our day. Love it. Show explanation. C, liver transplant. And really the thing that's critical to remember for this case is if you have a patient who potentially qualifies for an additional 22 points for the MELD exception points, that's going to get them on that transplant list when they qualify. And so this patient actually meets those criteria. So they have lesions of appropriate size, cutoff, and number, so 3 separate lesions, and that's using Milan criteria. And none of them are too big. They're all 3 centimeters or less. So that automatically qualifies them. And then they're really a candidate for liver transplant because this is acute. And in general, it's better to use MELD versus Child-Pugh scores because they align with the Milan and UCSF criteria. Okay. Thanks, everyone.
Thank you very much, Dr. Deal. I would like to invite all of our panelists and co-chairs to come back on, and want to have the audience join me in an extended virtual thanks and applause for just a phenomenal panel where they shared their time and their expertise for what was a great kickoff to this year's General Surgery Review Part 1. Thank you all very much for being here and contributing that expertise. As we close out, we want to remind folks again to join us in Tampa, Florida in March for the SAGES 2026 annual meeting. I promise you will have a phenomenal time and you will see all of us in person there as well at that meeting too. So we welcome you to attend. I also want to give you a preview for the part 2, where we'll go over several more topics with a whole new panel of experts that we will invite to go over the remaining topics in the ABSITE topic outline. That will be on January 13th, 2026. Please look out in your inboxes. Please spread the word to those as well who might benefit from this session. Today's session will be recorded and will be put up on the SAGES website and YouTube channel in a few weeks. So we look forward to encouraging you to that. In the meantime, we will see you in January. Between now and then, I wish everybody a safe and happy holiday season. Be safe and be well. There is a survey in your Zoom link. Please click on that. We really appreciate your feedback. Just take a few seconds to give us that feedback as we close out. Thank you, everybody. Thanks to the panelists. Have a good night and good holiday season.
Thank you. Bye. Happy holidays.